Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing about malignant salivary gland tumors. We'll talk about the risk factors involved in it, what is the classification here, what are the clinical features you see in these cases, and how will you investigate and treat the cases. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So, the incidence of malignant salivary gland tumor is actually lesser than the benign salivary gland tumors. It is about zero point 0.5 per 1 lakh person per year, and all the malignant salivary gland tumor accounts for only less than 5% of all the head and neck cancers. Now let's talk about what are the risk factors which can lead to the development of malignant salivary gland tumors. So we have about 4 or 5 of them. So starting with the most common, most associated risk factor over here, which is radiation exposure. Now, in terms of radiation exposure, we have seen that atomic bomb survivors they have an increased risk, especially to developing mucoepidermoid carcinoma. Secondly, other than this, even therapeutic head and neck radiation, for example, say for childhood cancer treatment, if you have been exposed to therapeutic irradiation as well, that could also be a possible risk factor to developing malignant salivary gland tumors. And the latency period between exposure and the time of developing of symptoms is actually a very long time. That is about 10 to 20 years of time. So that is our first risk factor. Second is our occupational risk factor. So all workers who are associated with industries where you're exposed to rubber, nickel, asbestos, silica dust, plumbing, woodworking, mining industries, all of them have an increased risk of developing these tumors. Other than that, also it has been seen that workers who are involved with livestock feed processing, they are also possibly related to an increased risk. Why? That is because of these livestock feed processing, they get exposed to these naturally occurring mycotoxins which are produced by aspergillus, and this can actually be one of the most carcinogenic substances you can be exposed to. So these are all the occupational exposure that can increase your risk of developing malignant salivary gland tumors. Next, coming to viral associations. Now, coming to viral association, they have been associated, but it has not been completely proven beyond doubt. So, the associations are Epstein Barr virus has been seen to be associated with undifferentiated parotid carcinoma, and cytomegalovirus has been associated with mucoepidermoid carcinoma. Next is nutritional factors. There has been an inverse relationship seen between a diet rich in polyunsaturated fatty acid and salivary cancer. That means a diet which is rich, if you have been exposed to a diet which is rich in polyunsaturated fatty acid, there has been seen to be a decreased incidence of salivary cancer. Lastly, there's some genetic and molecular alterations also noted in these different cancers. Amongst them, the two common cancers that are here, first is mucoepidermoid carcinoma, where we see a CRTC1-MAML2 fusion of gene. And second important one is an adenoid cystic carcinoma, where we see a MYB-NFIB fusion of the genes. So these are some genetic alterations we see and which has been associated with malignant salivary gland tumors. And lastly is age, the factor of age. Now, just like all other malignancies, here we also see an increase in the incidence of malignant tumors after about fifth decade of life. So these are all our risk factors towards developing malignant salivary gland tumors. Now we'll talk about the histogenesis. What's the pathogenesis behind development of these tumors? What are some theories that can be used to explain these tumors? So there are two such theories. First, I'll talk about the multicellular theory, which is the older theory. Now, this, if let's look at the image over here, this is what a normal salivary gland looks like. You can see the parts are here is acini, myoepithelial cells, which are over here on the outside. Acini are towards the intraluminal side. Then here is the intercalated duct, and here is the striated duct. So this is what salivary gland normally looks like, and these are all the different cell types that we can find over here. Now, multicellular theory, what it states is all the different malignant tumors, which I will be talking about in a little bit, where I'll give you a whole classification of the malignant tumors. So, all these different malignant tumors, they come from different types of mature cells, which are present in the salivary gland. So, what is basically saying is each of these cell types that we are seeing here, they are responsible of giving rise to different tumor types. For example, the first cells that we are seeing here is the acini. So these acinar cells is where acinic cell carcinoma arises from. Next, the intercalated ducts. These intercalated duct cells are responsible for giving rise to adenoid cystic carcinoma and polymorphous adenocarcinoma. Then excretory duct cells, which you're not able to see here, excretory duct cells are responsible for mucoepidermoid carcinoma, which is one of the most common malignant tumors of the salivary gland. Then salivary duct carcinoma and squamous cell carcinoma. And these myoepithelial cells that you're seeing over here, they are responsible for giving rise to myoepithelial carcinoma and basal cell adenocarcinoma. So basically, what the multicellular theory is telling you is that all the different normal cells that we are seeing in the salivary gland, they are responsible for these different tumor types. So all of these cells have a particular tumor type that it gives origin to. So basically, tumors have all of these multiple cells of origin, and that is why we are calling this as multicellular theory. The next theory, which is more modern and more widely accepted, is the reserve cell theory, also known as the stem cell theory. Here, basically, the explanation of this theory is that both a normal salivary gland as well as different tumor types like mucoepidermoid or adenoid cystic type, all these different tumor types, they all come from the differentiation of the same cell, which is the undifferentiated pluripotent precursor cell. So at the beginning, we have this undifferentiated pluripotent precursor cells. These cells then undergo different levels of differentiation to give rise to the normal salivary gland cells. Now, whenever there is any problem in this normal differentiation process, that's how we end up with tumor cells. So basically, the cells of origin are the same in terms of normal salivary gland as well as these different tumors. Any problem that occurs in the process of differentiation to form the normal salivary gland tissue, that is what gives rise to these different types of tumor. And second part is the fact that the earlier in this differentiation process that a problem occurs, the more undifferentiated and hence higher grade is the resulting salivary malignancy. Therefore, this cell theory is basically saying that there is a single stem like reserve cell, and that is the origin of all the tumors. So, these are the two theories that explain the histogenesis of malignant salivary gland tumors. Now, let's talk about the clinical features. What will we see when a malignant tumor arrives in each of the different salivary glands? But before we know that, let's also try to know which glands of the salivary amongst the salivary glands are more have more potential to develop malignant tumors versus benign tumors. So we know the largest salivary gland is the parotid gland. So in parotid gland, about 80% of the tumor that happens is benign. So only a small portion, which is 20%, is malignant. As you go down, as the size decreases, the next size is the submandibular glands. So in submandibular gland, the risk of malignancy increases compared to that of parotid gland. So we have 40% chances of malignancy in submandibular gland. And as the size of the gland reduces even further, which is the sublingual and the minor salivary glands, the risk of malignancy increases a lot. So there's a 90% chances of the tumor involving the minor salivary glands and the sublingual glands to be malignant. So what we conclude from here is that the smaller the size of the gland, higher would be the chances of malignancy. So, parotid being the largest gland is actually gonna have the least chance of developing a malignant salivary gland tumor. So, that's about the incidence and what is the percentage of malignancy in each of the different glands. Now, let's look into the clinical features. How will a patient present to you with as each one of these glands get involved? So, first we'll talk about parotid, which is the most common gland to be usually involved in a tumor, but however, the least likely to be a malignant tumor. So, in case of parotid, we know about the anatomy of parotid that there is a superficial lobe and the deep lobe, which is separated by the faciovenous plane of Patty. So, in the parotid gland, about 80 to 90% of all the malignant tumors they arise from the superficial lobe. So, this is the most common site of origin within the parotid gland. Now, some also arise from deep lobe. In case a swelling arises in the deep lobe, in that case, the presentation won't be a lump in the parotid region. Rather, the presentation in that case would be a swelling of the soft palate or the lateral wall of the oropharynx. So you will be seeing an intraoral swelling rather than an extraoral swelling over here. So whenever you're thinking of parotid gland, yes, most commonly you will be seeing over the angle of the jaw. But you also have to be aware that's not the only scenario, and you should also do an intraoral examination in your patients to rule out a tumor coming from the deep lobe. Next is 1%, very rarely. So, we have seen most commonly is the superficial lobe and then the deep lobe, but very less cases, in about 1% cases, it can also come from the accessory parotid gland, which lies along the Stenson duct. So these are the different sites of origin within the parotid gland. So usually, since we have spoken already about the superficial lobe, these tumors they will present to you with a asymptomatic discrete preauricular or infraauricular lumps. This is the majority of the presentation. And the second presentation would be a swelling of the soft palate or the lateral wall of the oropharynx. So it can end up displacing the soft palate, the uvula, the tonsil, and that's how it will present. Next, let's talk about what are some features of malignancy. Say a patient comes to you with a swelling in the parotid region, but it could be a malignant tumor or it could even be a benign tumor. How will you suspect a case of malignancy in these cases? For that, you would have to know what are the features of malignancy that you have to look out for. So these are, first of all, is a rapid increase in size. So a swelling that has been growing very slowly, and then you see that the swelling maybe has undergone malignant transformation, you'll notice that there has been a rapid increase in the growth of the size. Next, if there is any associated pain or paresthesia, if there is any associated cervical lymphadenopathy, or if there is any fixation to either the skin superficially or to the deeper structures underneath, or if there is a facial nerve palsy. In any of these cases, you will have to suspect for malignancy in the parotid swelling. So that's about the presentation of the parotid tumors which are malignant. Now let's talk about submandibular tumors. So when there is a submandibular gland tumor, we will be seeing a very slow growing, painless swelling under the jaw in the submandibular triangle. Occasionally it can distort the floor of the mouth. Very rarely you may see ulceration or skin invasion. Very rarely you may see local nerve paralysis. A very important MCQ question here is, what is the most common nerve involved in case of submandibular tumors? The first one would be hypoglossal nerve. Second most common is the trigeminal nerve. And third most common is the marginal mandibular branch of the facial nerve. So these are the most common nerves involved in case of a submandibular tumor. Other than this, even submandibular gland malignant tumor can have associated pain in about 30% cases and cervical lymphadenopathy in about 25% cases. So in these cases, it can involve the 1B lymph node, level 2, 3 lymph nodes. Next, we move on to minor salivary gland tumors. So, minor salivary gland tumors can basically involve any place where the minor salivary glands are present in the oral cavity, in the oropharynx, in the laryngeal region, anywhere. The most common site, however, amongst all minor salivary gland tumors is the hard palate. Usually, the swelling, what will it look like? It'll have a painless submucosal swelling with fixation of the tumor to the overlying mucosa. You can find a small central area of ulceration. Sometimes the patient may not come to you with a complaint of swelling, but rather they might say that the dentures that used to fit them properly are not fitting them properly anymore. They have ill fitting dentures. So when you remove the denture and you examine the palate, you can end up seeing this submucosal swelling in the palate. If the nose or nasopharynx gets involved, in that case, you will be having obstructive nasal symptoms. And in 25% of the cases, you will see pain or paresthesia. So that's about the clinical presentation of all the different salivary gland malignant tumors. Now let's talk about the staging. So we have the TNM staging over here. So according to the TNM staging, coming to first the T staging. So T1 is when the tumor is 2 centimeter or less without any extra parenchymal extension. So what is extra parenchymal extension? This means if there is any clinical or macroscopic invasion of the soft tissues or nerve other than those which are listed in T4A and T4B. Then T2 is when the size is more than 2 centimeter but less than equal to 4 centimeter. Again, without extra parenchymal extension. T3 is when it is more than 4 to 6 centimeter and or extra parenchymal extension. So the extra parenchymal extension gets introduced from T3. Then T4A is when it has invaded skin, mandible, ear canal, and or seventh nerve. And T4B, which is the last stage, is involvement of base of skull, pterygoid base plate, or carotid artery. That's about the T staging of salivary gland tumors. Next, coming to the N staging, N1 is when there is metastasis in a single ipsilateral node, 3 centimeter or less in greatest dimension without any extranodal extension. So the key terms here is single ipsilateral and 3 centimeter or less. N2A is when there is single ipsilateral but more than 3 to 6 centimeter. N2B is multiple ipsilateral less than 6. N2C is bilateral or contralateral less than 6. N3A is when the size changes, which is more than 6 centimeter. But again, till N3A, we do not have any extranodal extension. The moment you reach N3B, anything which has an extranodal extension classifies as N3B. So how do we remember this? N1, we are starting from N1. So N1 is when there is single ipsilateral 3 centimeter or less. Then coming to N2A, again single ipsilateral but more than 3 to 6 centimeter. Then we come to N2B, which is multiple ipsilateral less than 6 centimeters. So the term multiple gets introduced here. N2C is when there is bilateral or contralateral less than 6 centimeter. And N3A would be anything that is more than 6 centimeter but there is no extra nodal extension. And N3B would be anything which has an extra nodal extension. Next, coming to M staging, M0 is for no distant metastasis and M1 is for distant metastasis. And then this gets grouped into the different stages. There is stage 1 to stage 4C. That's how we do staging of malignant salivary gland tumors. Next, let's look at the classification of malignant salivary gland tumors. So according to the WHO 2017 classification, the classification consists of 22 such varieties. The most common ones being mucoepidermoid carcinoma, adenoid cystic carcinoma. These two carcinoma I will be talking about in separate videos. Other than this, there is acinic cell carcinoma, there's polymorphous adenocarcinoma. Polymorphous adenocarcinoma was earlier known as plague. I will talk about this in a little bit. Other than this, there is clear cell carcinoma, basal cell adenocarcinoma, intraductal carcinoma, adenocarcinoma not otherwise specified, salivary duct carcinoma, myoepithelial carcinoma, epithelial myoepithelial carcinoma, carcinoma ex pleomorphic adenoma, which is basically carcinoma developing in a previously benign pleomorphic adenoma. Then there is secretory carcinoma, sebaceous adenocarcinoma, carcinosarcoma, undifferentiated carcinoma, large cell neuroendocrine carcinoma, small cell neuroendocrine carcinoma, lymphoepithelial carcinoma, squamous cell carcinoma, oncocytic carcinoma, and lastly, cyeloblastoma. So that's all about the classification of malignant salivary gland tumor. Now let's talk a little bit about some of the common ones. So the first two most common ones, which is mucoepidermoid carcinoma and adenoid cystic carcinoma, will be discussed in a separate video. The third one is acinic cell carcinoma. Now acinic cell carcinoma, important points here is that this is a low grade tumor. This occupies only 3% of all salivary gland tumor. The most common site is parotid in about 90% cases. Again, here we have a female preponderance. This is common in the fifth decade of life. The origin, as I described before, according to the multicellular theory, it originates from the acinic cells. It is bilateral in about 3% cases. On gross macroscopic features, we see a solitary encapsulated lesion, meaning it has a capsule, but it can also have multilobulation. And on microscopy, the different histologic patterns can be solid, microcystic, papillary cystic, and follicular. And acinic cells, how do you recognize them? They look like round cells with very dark eccentric nuclei and basophilic cytoplasm. These acinic cell carcinoma, since the most common involvement is a parotid, they usually present as a very small, firm, movable swelling in the parotid region. Very rarely, in about 10% cases, you can see involvement of facial nerve or lymph nodes, and they have a variable consistency with soft and as well as cystic areas. So that's a little bit about acinic cell carcinoma, and these are the different MCQ points that you need to remember. Next is polymorphous adenocarcinoma. Now, the polymorphous adenocarcinoma, it was actually earlier known as PGLA, which is polymorphous low grade adenocarcinoma. So, basically, prior to 1983, it used to be considered as a low grade variant of the adenoid cystic carcinoma. So, this type is actually less aggressive and it has a better prognosis. The most common site here is not the major salivary gland, rather, it is the minor salivary gland, and amongst that, also, the region would be the palate. Rarely involves the major salivary gland. Recurrence can occur very late in follow up. So, local recurrence can be seen at 15 years after initial treatment, and regional recurrence can be seen at 10 years after initial treatment. The different histological patterns here are tubular, cribriform, papillary, and lobular. And polymorphous adenocarcinoma, actually, it is very commonly mistaken for two different types of benign. One of them is a benign tumor, one of them is a malignant tumor. So it gets mistaken for pleomorphic adenoma because of its variable appearance, and it gets mistaken for adenoid cystic carcinoma due to comparable growth patterns and the presence of neurotropism, which is basically involving the nerves. So that's a little bit about polymorphous adenocarcinoma, which was previously known as PGLA. Next, let's talk about adenocarcinoma. This occupies about 8 to 18% of all parotid cancers. This is a very aggressive one with advanced locoregional extension at diagnosis. There's perineural growth in these cases and positive resection margins. Histology shows tubular, papillary, and undifferentiated patterns, and in 20% cases, there's involvement of the facial nerve. Next is carcinoma x pleomorphic adenoma. So, in carcinoma x pleomorphic adenoma, this, as I mentioned a little while back, this actually arises in a pre existing pleomorphic adenoma. And the risk of this happening is about 10% by 15 years of the pleomorphic adenoma. They may be malignant either right from the onset or it can also undergo carcinomatous transformation. 7 to 16% risk in recurrent cases. And these are cases which are poor in prognosis. And the last one we'll discuss about is the squamous cell carcinoma, which is a very rare tumor here. So, the most common site for this is the parotid, and it's almost never seen in minor salivary glands. This is a high grade tumor, so hence it is very aggressive. More commonly seen in males, seen in 6th to 7th decade. So, this is an aggressive, non encapsulated. So, this one does not have a capsule arising from the ductal system, grows rapidly, causing pain, facial palsy, skin fixity, and ulceration. And it spreads commonly to the neck nodes and has a very poor prognosis. So that's all about the different commoner types amongst the classification that I mentioned to you. Now let's go into how will we investigate these cases and later on how will we treat these cases. So coming to investigation, our first line imaging would be to perform an ultrasound for the superficial reasons, and ultrasound will also help in guiding FNAC. It increase the accuracy of performing FNAC. Next, we'll perform a CT scan. Now, CT scan, when do you do it? This is indicated when either there is impaired tumor mobility, when the tumor is large, which is more than 4 centimeter, there's involvement of the facial nerve and there is palpable cervical nodes. In these cases, we'll perform a CECT. So this will help us in defining the extent, calcification, bone erosion, and the nodal disease. Next, coming to MRI. Now, MRI is actually because this is a soft tissue tumor. This MRI is actually more important over here because it is much more superior to performing a CT scan because of its soft tissue delineation. So, MRI will help you better demonstrate these different regions like the retromandibular parotid area, stylomastoid foramen area, facial nerve invasion, and possible perineural spread. Even amongst MRI, diffusion weighted MRI has been seen to have more efficacy in identifying malignancy. So these last imaging method here is PET-CT. This is usually used for doing staging to detect metastasis in advanced cases. However, important part to remember here is there may be high false positive rates because in terms of differentiating benign from the malignant tumors, we have seen that certain benign tumors like the Warthin's tumor and the pleomorphic adenoma, they demonstrate an increased FDG uptake. So there can actually be a false positive rate, higher false positive rate in terms of doing PET-CT in malignant salivary gland tumors. So these are the 4 different imaging methods that we'll do. Next, looking to the fine needle aspiration cytology, we'll use this as an initial investigation to diagnose what could be the possible case. And secondly, core needle biopsy, which is usually not done. We only perform it when fine needle aspiration cytology has been inconclusive. So these are all the investigations we'll be performing in a case of malignant salivary gland tumor. Now we'll talk about the different treatment methods over here. So first of all, base treatment is always going to be surgery. Then along with surgery, we could use radiotherapy as an adjuvant therapy in selected cases, but our mainstay of treatment over here is going to be surgery. And later on, we'll discuss the role of radiotherapy and chemotherapy in unresectable cases, in cases where we are not able to do surgery. So first, talking about surgery, we'll start with the different salivary glands. First, let's talk about the parotid gland. So in parotid gland, first let's talk about the treatment of the primary over here. So in case of the primary, we will be doing a primary surgical excision and will depend the extent of this resection that we'll perform over here will be determined by the size of the lesion, the relationship to facial nerve, and whether there is any extraparotid tissue invasion. So the different options here are, first of all, is superficial parotidectomy. So we'll perform here is we'll remove the tumor along with the superficial lobe of the gland, and we'll identify and preserve the facial nerve. So this will be done only if the tumor has been confined to the superficial lobe with no facial nerve involvement, and the tumor is of low grade and it is mobile. In these cases, we'll be doing superficial parotidectomy. Next, we have total parotidectomy and radical parotidectomy. So, total parotidectomy is when we remove the entire gland along with the facial nerve, and radical parotidectomy when it extends a little bit beyond that to involve other adjacent structures like skin, masseter muscle, mandible, etc. So, this is done when tumor is more than 4 centimeter. There is involvement of the parapharyngeal space or the deep lobe. There's involvement of the facial nerve, or this is a high grade tumor. So these are the two options of parotidectomy over here. Now, what are the indications where we have to sacrifice the facial nerve in these cases? First of all, the first indication is if there is a preoperative weakness or paralysis of the facial nerve. Second, if say preoperatively there is no problem, we do not see any facial paralysis, but intraoperatively during the time of operation we find evidence of gross invasion. In that case also we have to remove the facial nerve. And third indication is if the tumor is going through the facial nerve from the superficial to the deep lobe. I have mentioned before that the superficial and the deep lobe, they are separated from each other by the facial-venous plane of Patty, which involves a nerve, vein, and an artery. The nerve which is passing here is the facial nerve. So, when the tumor is going from superficial to deep lobe, sometimes it can go through the facial nerve. In these cases, we have to remove the facial nerve as well. So, this was about the surgical part. Next is postoperative radiotherapy. Now, usually after surgery, we give postoperative radiotherapy so as to reduce the chances of relapse here. Usually, the timing of this is 3 to 6 weeks after the surgery. Dose is 50 to 70 gray, 1.5 to 2 gray in 5 to 8 weeks. If we have removed the facial nerve or a part of it and done nerve grafting, in that case, we should delay it for 6 weeks. So, the indications of postoperative radiotherapy are if it is a later T stage tumor like T3, T4, high grade tumors, perineural spread, adenoid cystic carcinoma in histology, deep lobe tumor, vascular involvement, multiple neck node involvement, or if it is a recurrent tumor. So, this is about how we will treat the primary tumor in case of parotid. Now, say in the parotid case, there is a neck node involvement. How will we treat this? Depending on what is the position of the neck node. So, if this is a neck node positive case, so we'll have to first see if it is a clinically positive case. In that case, we'll definitely be performing modified radical neck dissection, and we'll remove level 1 to 5. How do we decide what structure to remove? We'll see based on invasion or proximity to the metastatic disease, the different 3 non-lymphatic structure, which is the 11th cranial nerve, the jugular vein, or the sternocleidomastoid, they may need to be removed. If this is not a clinically positive disease, but a pathologically positive disease, in that case, we will give post-operative adjuvant radiotherapy to the parotid and the ipsilateral neck area. So this is when clinically or during the time of surgery, you have not found any neck node involvement. But when you have performed the biopsy, when you have gone through the biopsy and histopathological examination, you have found it to be pathologically positive. So in that case, we will be performing a post-operative adjuvant radiotherapy. Now, say there is no neck disease. This is N0 patient. So, there is clinically N0 patient at presentation. Do we still perform elective neck surgery or do we let it be? So, in this case, we'll perform an elective neck surgery only if there is any one of these risk factors present for occult neck disease. Now, what are these risk factors? These risk factors are, first of all, if the tumor is large, more than 4 centimeter, if the any histology which has a very clinical high grade behavior, if the age is more than 54, if there is perilymphatic spread, if there is extraparotid extension. So these are all the risk factors where there's a higher risk for occult neck disease. So in these cases, even if you have a clinically N0 neck at presentation, we will be performing elective neck treatment, which is either we'll do a neck dissection or we'll do radiotherapy. In these cases, what we can also do, where there's a clinically N0 neck, we can send a frozen section of the level 2 nodes at the start of your surgery. If that comes up to show macrometastasis, in that case, we'll consider it as a clinically N positive and we'll do a modified radical neck dissection over here. Another thing to know here is something known as the MD Anderson strategy. This strategy states that you give elective radiotherapy to N0 neck in high risk patients relying on definitive histology of the resected primary. So, this has been all about the treatment of parotid tumor, malignant tumor, along with neck involvement. Now let's talk about submandibular gland. So submandibular gland, if there is involvement and this is a tumor which is at an early stage, low grade and clinically N0 disease, which means that there is no clinical lymph node involvement, in that case, we should perform an excision of the submandibular gland and along with that level 1A, 1B lymph node removal. But say it is still a clinically N0 disease, but all other cases, which means it is not an early stage or not an low grade tumor, in that case, we will remove the submandibular gland, but the lymph node removal will be way more. Here, in this case, we'll be removing level 1, 2, and 3 elective neck dissection. Now, when do we go beyond level 1 to 3? That is done only when the tumor directly extends into the nearby structures, for example, the floor of the mouth or the mandible. In these cases, we can remove beyond level 3. So, this was all about the clinically neck N0 cases. But if we see clinically node positive disease, in that case, we should perform a comprehensive neck dissection where we remove level 1 to 5. So this is about the treatment strategy in case of submandibular gland. Next, let's look at sublingual gland. So in sublingual gland, the most common malignant histology type that we see here is the adenoid cystic carcinoma, seen in about 72% cases. And the second most common is mucoepidermoid carcinoma. Coming to the treatment plan here, first, let's talk about the primary. If the tumor is small, which is less than 2 centimeter and it is mobile, in that case, we will excise the tumor intraorally and we should also remove ipsilateral submandibular gland or level 1 lymph nodes because more often than not, submandibular duct also needs resection in these cases. But if the tumor is larger, which is more than 2 centimeter, we need to do a en bloc resection. What does that mean? Here we remove the tumor along with the surrounding tissue as one whole block. This may need a more extensive approach such as a pull-through procedure or a mandibulotomy. So this was about the primary treatment. Next is neck node management in case of sublingual gland involvement. If clinically it is a N0 case, and there is no neck node involvement, we will still perform an elective neck dissection of level 1 to 2A. This will basically help you in reducing the chances of recurrence. But if we have a clinically N plus case, in that case, we'll be doing a modified radical neck dissection and this is mandatory. So that is about the neck management. Now we'll talk about adjuvant post-operative radiotherapy. So this we give post-operative radiotherapy in very advanced cases. Indications would be almost the same as before I've mentioned. Stage 3, 4, high-grade tumor, perineural involvement, positive surgical margins, more than 2 positive neck nodes involved, and pathological evidence of extracapsular extension. So, this is about the sublingual salivary gland treatment. Last of all, we'll discuss the minor salivary glands. So, in terms of minor salivary gland, a primary tumor treatment would be to perform a wide local resection and to leave tumor free margins. And here, resectability will depend on what findings we have clinically and in terms of investigations, and what anatomical site of origin is involved, and also what is the histology of the tumor. Next, coming to neck disease. In here, the indications of surgery in cases of minor salivary gland tumor in terms of neck is if we find clinical or radiological evidence of regional node metastasis, if the risk of subclinical disease in a clinically negative neck exceeds 15 to 20%, and if the neck is surgically entered as an approach to primary. These are the indications of surgery. So we have a clinically node positive case, we perform a modified radical neck dissection. And if we have a pathologically positive node disease, in that case, we can just give post-operative radiotherapy. So this is about the treatment of minor salivary gland malignant tumor. Now let's talk about a little more specific in terms of the different sites in minor salivary gland tumor. So first, coming to oral cavity, the common sites over here, the most common one is palate, which is seen in about 60% cases. Other than that, there's buccal mucosa, retromolar trigon, upper lip, etc. The common histology, which is seen in 90% cases, involve mucoepidermoid carcinoma, adenoid cystic carcinoma, or polymorphous adenocarcinoma. So, in case of involvement of the oral cavity, especially the palate, you perform a wide local excision with or without partial palate removal. And then you have, if there is a large defect left behind, we can do a free flap reconstruction. Next is oropharynx. The most common site here is involvement of the base of tongue, and the most common histology would be adenoid cystic and mucoepidermoid carcinoma. In these cases, again, we'll be performing a surgical excision, but that will basically depend on case to case as to which type we use. It can be a transoral laser microsurgery, transoral robotic resection for smaller lesions, suprahyoid release or mandibulotomy, and free flap reconstruction for larger tumors. And most cases in oropharynx involvement requires post-operative radiotherapy. Next is larynx. In larynx, the sites usually are subglottis submucosa. In the glottis, there can be ventricle involvement, undersurface of anterior commissure involvement. Supraglottis, there can be involvement of the array-epiglottic folds or the petiole of epiglottis. And histology in larynx cases are usually adenoid cystic and mucoepidermoid. Again, treatment is surgical resection. It can be an endoscopic resection or an open partial laryngectomy or a total laryngectomy. Next, coming to nose and paranasal sinus, the most common histology here is adenoid cystic carcinoma. Treatment, if it is resectable, we'll perform surgery, which can be endoscopic resection or lateral rhinotomy, midfacial degloving, or craniofacial resection. Or if it is unresectable, in that case, we give primary radiotherapy. Last site is nasopharynx. Here also the most common histology in 94% cases is the adenoid cystic carcinoma. Here most of the times the tumors are unresectable, in which case we give primary radiotherapy. But if it is feasible to resect completely the disease, there can be different approaches like lateral infratemporal fossa approach, subfrontal approach, midfacial degloving approach, lateral rhinotomy, transoral palatal approach, or maxillary swing approach. So this was about the different surgical options involved in case of minor salivary gland tumor. Now coming to post-operative radiotherapy in minor salivary gland tumor, usually in most cases we recommend to use adjuvant post-operative radiotherapy in after resecting the tumor and pathologically staging it. The only exception in this case, if there is a clear margin early stage disease, meaning stage 1 and 2, without any lymphovascular or perineural invasion, in that case we can choose to not do post-operative radiotherapy. The indications of post-operative radiotherapy in minor salivary gland tumors would be if there is positive margins or closed surgical margins, high-grade histology, perineural growth, bone and muscle invasion, paranasal sinus localization, and high T and N classification. So that's about the treatment for minor salivary gland malignant tumors. Next, last part is radiotherapy and chemotherapy in unresectable disease. When do we use them? So, first, let's talk about radiotherapy. The radiotherapy as the primary treatment, the indications for this are if the patient is inoperable for some reason, if the patient refuses surgery, and if the tumor is unresectable. In these cases, we have different options of radiotherapy that we can use. So, in conventional photon radiotherapy, the 10-year local control rates have been seen to be 17 to 57%. In modern techniques like intensity modulated radiotherapy or proton or carbon ion boost, they have improved local control and lower toxicity than the conventional route. In neutron radiotherapy, the 5-year local control rate is actually very high, 75%, especially in adenoid cystic carcinoma. And there are other new approaches like gamma knife boost after neutron radiotherapy, which have better controls, concurrent chemoradiation, which also has good tumor control, and the third one is re-irradiation and chemotherapy for a recurrent case, where we also see a good loco-regional control rate of 72% at 1 year. And lastly, chemotherapy. Chemotherapy has very limited role in terms of treatment of malignant salivary gland tumors. There's only palliative role over here. And in metastatic adenocarcinoma with not otherwise specified, they are the ones who show some good response with chemotherapy, with particularly these agents, which are cisplatin, doxorubicin, and cyclophosphamide. But responses are very short lived. So that's about the malignant salivary gland tumors. If you have any further question on this, please note them down in the comment section and I'll get back to you. Thank you.